Thank you everybody for joining us today in the final webinar of 3 following the launch of our policy brief on the backlog. My name is Ewout van Ginneken of the European Observatory in Health Systems and Policies, and together with Erica Richardson, my colleague, I will be moderating this seminar. So today's topic will be about measuring waiting times, waiting list and backlog, especially after COVID. As you all know, the COVID-19 pandemic has caused health systems to postpone non-emergency procedures to keep capacity available for COVID-19 patients, but also to avoid elective patients to get infected. These disruptions led to high unmet need, longer waiting lists, and also longer waiting times. And in the webinar today, we will be discussing this. So first of all, what is the backlog exactly? How can we define it? What about waiting lists and waiting times? What's the difference here? How can we quantify waiting times in our health systems? And then importantly also, how can these be used for better informed policymaking? We will do this with the following speakers. Our keynote speaker today is Luigi Siciliani. Luigi is a professor of health economics at the University of York. And many of you will know him for all his work on waiting times. So he's the right person to give this keynote. And he was also one of the co-authors of the brief, the policy brief that we produced. Then the next speaker is Florian Tille from the Observatory Hub in London. Florian was also co-author of the brief. And he will give a more European perspective and talk about the Pulse survey done by WHO, where he has collaborated with, and show how disruptions all over the continent are affecting also the backlog. Then we will have 3 case studies, country case studies. The first one we will hear from Catalonia, from Ana Garcia Altes. She's an economist in the Catalan Department of Health, and she's also published widely also on waiting times, and she will discuss situation from Catalonia and also a little bit of Spain, I believe. Then we will hear from Pia Tuominen from the Finnish Institute for Health and Welfare, where she works in the Health and Social Services Data and Information Management Division. And her area of concern is also non-urgent specialized medical care, where they also track those waiting times. The final speaker today will be from France. It will be Aidan Tajamadi, and Aidan was here last week for those of you who were there as well. And he's the Deputy Director of the Department for Strategic Research, Studies and Statistics at the CNAM. And the CNAM is the French payer in the health system, kind of a sickness fund. And he has been really involved in research of the impact of the COVID-19 pandemic on the French health system. And they also track volumes in their health system, and we'll hear from them. Now, just really quickly to Erica before we start with the program. Erica.
Hello, everyone. Welcome to the webinar. Please do put any comments and questions in the chat box. You're welcome to interact with each other, but I'll be synthesizing all the questions for the discussion part at the end. So I'd recommend you get your questions in early so you don't get disappointed. Okay, thank you very much. Back to you, Ewout.
Thank you, Erica. Now it's time for you, Luigi, so the floor is yours.
So let's go straight into my presentation. So I'm going to cover 4 main measures that relate to the backlog. So if you think about measuring the backlog, I want to emphasize 4 types of numbers that you can collect. One is the waiting list, the other one is volume and referrals, and then the last one is waiting times. So just to motivate a little bit, this is I'm going to use quite a few data from England to illustrate some of the concepts. So if you look at the waiting list, how this has evolved over time and the pre and post COVID, we can see in this slide that pre-COVID the waiting list was around 4 million, and then now it is above 6 million. So that's a quite rapid increase in the waiting list, though we can see that the waiting list was already growing before. So that's probably an important point to highlight. So what I want to do next is to try to explain what is the main dynamics of the waiting list, what is that drives that, and how does that relate to the backlog. So this is, I'm going to start with volume. So if you think about how volume evolved over time before and after COVID, so if you think that volume was stable before COVID, then suddenly it dropped and there was like a big disruptions in volume, and then slowly volume started to recover again. And this is where we are now. We are still catching up on volume, but we don't know is how volume is going to evolve over in the future. So in this slide, I made like what I call like an optimistic scenario, where the volume is gonna in the future is gonna grow at a faster rate relative to the pre-COVID level. And then on this diagram on the left, there is the waiting list, and you can see that as a result of the backlog, which I have defined as the difference in volumes before and after COVID, how the waiting list can grow quite quickly as a result of this accumulated or disruptions in volume. So the next slide really shows you the same with some colors. So you can see how the waiting list quickly builds up as a result of the reduction in volume. So in the first period, quarter or 6 months, the volume reduces by the blue area, which is immediately increases the waiting list. And then in the second period, you have the smaller green area gap, which also contributes to increasing the waiting list. And then the increase keeps reducing until finally the volume catches up. So again, in this optimistic scenario, when the volumes finally start to grow at a quite high level, then you can see the waiting list going down. So you may say, well, actually, these increase in volumes haven't happened yet, at least in England, as I'll show you later. Maybe some countries have already increased the volume at higher levels relative to the pre-pandemic level, but I think this is still quite rare. So what happens if the volume only catches up to the pre-pandemic levels? So we just go back to the levels that we had before. Well, in that case, we still have the backlog, but then the waiting list will stabilize. So that's still like mixed news, because you still end up with this very high waiting list, and will stay at that level. So unless the volume really goes at a higher level relative to the pandemic level, we'll still have this very long waiting list for a long time. And then the worst case scenario is where actually the volume still doesn't catch up to the pre-pandemic level for quite some time. And then what we see is that as after the big jump due to the backlog, the waiting list keeps growing slowly, because still there is a gap between the patients that are added to the waiting list and the volume. Now, some of you may be thinking at this stage is that, but those additions to the list and the referrals have also dropped during the pandemic. So how does that affect the waiting list? So that's what I'm exploring next. So it is true that in quite a few countries, the referrals, not only the volume dropped, but also we can see in the data that the referrals were fewer during the pandemic. Now, if you see that if we will have a permanent reduction in those referrals, well, that's good news for the waiting list, because you can see that the backlog that we have accumulated is smaller, and then that will also help it to reduce the waiting list over time. But we have to worry about why are these patients not showing up in the referrals? So to me, that's an indication of unmet need. If those patients who before were demanding treatment, if these were hip replacement patients who had pain, why there are fewer patients now showing up in the waiting list as additions to the waiting list? So that seems an important point that we really need to keep an eye on monitoring the referrals and the additions to the waiting list, because that could be an indicator of unmet need. And another scenario that is the last one I want to show is one where maybe what we have observed is that there is a temporary reduction in the referrals, but eventually these referrals will catch up. So this is what we see in this graph here. So if eventually those patients who didn't manage to see their GP, but finally they manage to see them, and then they get their referral, then we'll see some referral rates that could be potentially be higher than the pre-pandemic level, and that will also contribute to increase the waiting list. So that's the main dynamics of the waiting list, as a function of volumes and referrals. Now, let me give you now like a small case study. So this is the waiting list for England that I showed you at the very beginning. This is what is happening to volume, and this is taken from the Nuffield Trust Quality Watch. So what you can see here is that for both inpatient and outpatient, we still haven't caught up with the pre-pandemic levels. So we're getting there, but we're still below. So if you kind of make the link with the previous slide, you can see that the waiting list potentially is still growing as a result of that. Here I also show the referrals, and you can see that the referrals have dropped. So in that sense, that maybe is attenuating the effect of the increase on the waiting list, but that's also an indication that possibly there is an unmet need out there, because some patients that were expressing need before, now they're not expressing it before. Okay, so what about countries that do not have statistics on waiting times or waiting list? What could they do? Well, I think what they can do is still to look at the volume. So this is what I've tried to draw in this diagram. So I think if we compare the volume levels post-COVID and compare them to the pre-pandemic levels, I think this is potentially a proxy of unmet need. So as long as the volume doesn't catch up, this is potentially a quick and ready measure of how many more patients do you have to treat in the future in order to catch up with that backlog. And that's what I've drawn here in this green area. So ideally, we would like to recover those patients and increase the volume to a level that has recovered all the blue area. This is like a simple diagram along those lines. This is from a diagram from the British Medical Associations, with just in a very simple way plots elective procedures and outpatient appointments for 2019 pre-COVID with the post-COVID levels. So by looking at the difference between these two volumes, you can have again like a measure of how much do you have to catch up in the future, at least in that year. Another thing you can do on volume is to look at the inequalities. So there is like a nice paper recently published in the BMJ, which shows how volume dropped during COVID. And what we can see here is that volume dropped in a reasonably proportionate way across different quintile of income deprivations, though possibly at the highest income deprivation quintile, it dropped by 2 percentage points, which is what this other diagram shows, after you have corrected for the case mix. So in that sense, you can do this type of analysis if you worry about inequalities and whether COVID affected volume in a differential way across different groups in society. You can do that, and that can be quite informative from a policy perspective. Now, my last 3 slides are on waiting times as opposed to waiting list. As a patient, I really don't care how many patients are on the waiting list. What I do care is how long I'm going to wait. So in that sense, this is always at some level my preferred measure of the waiting time problem, because again, as a patient, that's what I really care about. But there are some technical issues. So there are different ways to measure waiting times, and things get a bit complicated. So there are 2 main ways to measure waiting times. One is for the patients on the waiting list at a point in time. And the other one is the waiting time of patients who have been treated in a given period. And these 2 measures are quite distinct and have different properties and have different advantages and disadvantages. So the main problem with measuring the waiting time of the patients on the list is that by definition, this is an incomplete waiting. Because you're still waiting, you don't know how long you're going to wait. So that's one limitation of this measure. Another limitation of this measure is that it oversamples long waiting time patients, because the patients who wait short, they appear and disappear from the waiting list quite quickly, while the ones that they wait very long, they stay there for a long time, so they are more likely to be picked up by this measure. One advantage of this measure is that you can monitor, let's say, providers or hospital in a timely way, so you can always check the patients on the list today, and you can check very quickly how long they have been waiting. So that's the main advantage of why we see this measure used quite a bit, I think. Then the second measure is the one that is conceptually better because it measures retrospectively how long patients have waited. So that's the waiting time of patients treated in a given period. One limitation of this measure is that it excludes those that were never treated. So if you think about patients on the list and someone dies on the waiting list, you will not see that patient in the second measure. And then another limitation that is specific to COVID about this measure is that volume dropped quite a bit. during COVID in certain periods. And so the waiting time that you see in those periods reflect very few number of patients. So in that sense, that's also a limitation. So let me conclude by actually showing you some data for England on these two different metrics. So the first one is the one of the patients on the list. So you can see that during COVID, the median waiting times in weeks of the patients on the list went from less than 10 weeks to above 15 weeks. So there is this big peak. And then as volume started to grow again, then you see that the median waiting time goes down, and then it still remains at a higher level relative to the pre-pandemic levels. What you also see for the patients treated, these are the admitted ones, so the one that end up with an inpatient admission, you can see this strange anomaly in the graph that shows how waiting time actually dropped during COVID here. And but the reason for this is that there were very few patients who actually were treated during COVID, but those ones were probably urgent ones. And because the capacity of the hospital was still there, they were treated quite quickly with a shorter waiting time relative to the pre-pandemic level. Then again, as volume started again, then you can see that the waiting times started to increase again at a value that is like 10 weeks or above and stabilized over there. The other thing you can see in this graph is that the waiting time of the patients on the list, which is the incomplete waiting, is actually higher most of the times than the other one, which reflects this oversampling of the long waiting time patients. So you really have to think quite carefully about these different measures and what they're telling you. My very last point, and then I will draw to a close, is to think when we look at the waiting time, we have just looked at the median, or we could look at the mean, but there is a distribution of waiting times, with some patients waiting very short and some waiting very long. So it's really important to look at the waiting time along the whole distribution. So these plots the waiting time of the patients who wait longest at the 92nd percentile of the distribution. So only 8% wait longer than that. And you can see that during COVID, those who were waiting very long, we see like a very sharp increase in the waiting time for those who waited longest, that they reach 50 weeks, which is getting close to 1 year. So relative to the median waiting time, the increase for the long waiter is much higher, which suggests that in terms of inequalities in waiting times, that probably inequalities in waiting times in the waiting time experienced by the patient, there is like a bigger dispersion and therefore higher inequalities. Thank you. Please get in touch if you want to know more about some of these measures. Thank you.
Thank you very much, Luigi. And if anybody has questions about this presentation, please put them in the chat. I thought it was very insightful, and I understand that we need to track various measures instead of just one to be able to give the full picture. Now let's go to a European perspective. Florian, the floor is yours.
Good afternoon, everyone. I would now like to shine a spotlight today on what we know about the degree of the service disruption and the size of the backlogs of services across the WHO European region. To answer this, I would like to present, and this has been mentioned before, data from the 3 rounds of the polled survey on the continuity of essential health services that WHO has conducted since the outbreak of the pandemic. For these services, key informants and focal points and ministries of health across all countries in the region were asked to report on essential health services in their countries. In the first 2 rounds, there was February through August 2020 and August 2020 through February 2021. We found that in the region, 92% and 82% respectively of all countries experienced some service disruption during those periods. In the third and latest round that covered May through November 2021, it was found that countries across the region were still on a very large scale affected by the COVID-19 pandemic when it comes to disruption on services. Of the 24 countries that responded, 21 countries, equalizes 91%, reported disruptions to the essential health services during that period in their country. Importantly, also the majority of countries reported a disruption of 25 to 50% of their services. Looking at this graphic that I would like to show with you, we all know from the beginning that COVID-19 has led to substantial disruptions of services across all levels and all areas of care. The polled surveys provided data on that after COVID-19 initially impacted mostly hospital services, dental and mental health care. In 2021, disruptions gradually also increased in primary care and in emergency care, with more users who didn't receive these services compared to pre-pandemic levels. The second graph I would like to show with you now is that the survey also showed the services in most areas became less disrupted towards the end of 2021. But, and this is what I circled in red here, for first contact services such as nutrition services and cancer care, we have been seeing substantial increases in disruptions. Also, I would like to draw your attention to the growth of major disruptions in routine immunizations, while overall disruptions in this area had actually gone down. This is the purple one on the very left. And now looking at backlogs, through the Pulse survey, we have gathered evidence that backlogs have been building up in countries across service delivery areas, in line with what I've just presented on the disruptions. On this slide now, we can see the percentage of countries reporting an increase in backlogs across different areas in 2021. And the caveat here is that there's only relatively small numbers of countries who are reporting on this. So we do need to be a bit cautious about generalizing here. In any case, though, the key message is clear, I think. Backlogs have become larger in many countries. And I wouldn't be surprised if people in the audience with us today would report similar experiences from their countries. Speaking of limitations of the survey, some major ones that I would like to mention are that there clearly was at least some kind of reporting bias in the survey, as it's self-reported key informant data, and also it was up to the countries whether to report on the disruptions at all or not. Also, the process of completing the survey differed between countries. We had some countries where it was really one individual informant who provided the data, whereas we had other countries where it was a coordinated and validated response across different units at the ministry or other national health authorities. And the countries that participated across the 3 rounds were not identical. So we also need to be a bit cautious about comparing any trends over time. That being said, the Pulse survey has been considered a useful instrument to monitor the size of disruptions and backlogs across countries. WHO will continue this monitoring, and we're in the process of preparing a 4th round that is to be conducted by end of this year, and we're happy to present on the results next year when they're in. In the meantime, please feel free to find out more on the links that are provided here. The policy brief is what Ewout has just referred to and what we've heard about before. And the second link is the WHO dashboard that gives a pretty good visual overview of all the results that we were able to collect through the Pulse survey. With this, I conclude, and I'm looking forward to the discussion. Thank you very much.
Thank you very much, Florian, for this overview. And maybe you can also provide the links in the chat, so that's really easy for the people attending here to access it. So now we are moving to some country experiences, and I would like to ask Anna from Catalonia in Spain to give a perspective how they measure waiting times. Anna, the floor is also yours.
So thank you very much. We started in Spain. We started collecting data about waiting times in 2003. Mainly hospital surgical waiting times by a specialty and procedure. And the way it works is that every region, every comunidad autónoma that we call, send the data to the health ministry in Madrid. However, the problem is that historically, not all regions have sent their data. And moreover, this data is not homogeneous over time. So any comparison that you want to make longitudinally over time or with other countries has to be made very, very carefully. Waiting times are measured since the inclusion of the patient on the waiting list until surgery. If we can go to the next slide, so we can see some, yes, thank you. Some evolution since the beginning, 2003 up to now, well, up to 2021, how it looks like. So there's one peak. I don't know. Do you see where my pointer is? Well, there's a peak on the graph in 2012. That is when Madrid started sending the data. Yes, thank you. There's another peak in 2016 when Catalonia started sending the data. And then is the effect of COVID-19. A bit later. Yeah, thank you. The thing is that in Spain, we are in one of the cases that Luigi was commenting. I mean, the problem is not that much on the waiting list, but before the waiting list, primary care was totally collapsed and stopped. Visits to the specialists were totally stopped. So the backlog is mainly before going to having a surgical appointment. And we should measure carefully all of this effect. So there's a lot of heterogeneity, not constant reporting over time, and this effect of COVID later on. This is the visual on variability. This is on specialties. But you can see the big variability that there is, giving all this I was mentioning, in this heterogeneity among regions sending data. And next slide, please. And that's my last slide. Thank you to all of you, and a special thank you to Jaime Pinilla, who is at the Universidad de Las Palmas de Gran Canaria, who is probably the researcher in Spain who has published most on waiting lists. And he has this very nice paper on the Pinocchio testing. So I have done all the numbers with him, and we'll do some more detailed analysis in the near future. So thank you very much.
Thank you very much, Anna. Perhaps you want to provide also a direct link in the chat box to this paper and some other work that you've been doing in Catalonia and Spain.
Yes.
Okay, so now we are going to Finland, and we're going to hear from Pia how waiting times are measured in Finland. Thank you, Pia.
I work in Finland's Health and Welfare Institute, and my area of responsibility includes specialist care and statistics on waiting time list to specialist care. As of 2021, data on persons waiting non-urgent care for specialized care will be updated on a monthly basis in the National Institute for Health and Welfare databases, depending on the situation on the last day of the month. Data updated on a monthly basis are not subject to quality or completeness checks. The statistical report, which is published 3 times a year, examines the situation and changes in assess the specialist care at country level and at hospital district level. The quality report of the statistical report assesses the reliability and suitability of the statistics for the various use. Publication of the statistical report for April, August, and December. The change was made to monitor impacts of COVID. Therefore, the graphs I have presented, a number of waiting lists, is both of August and July, because I have not yet become aware of the numbers for the last day of August in this year. But I think August numbers are likely to be higher than in July in this year. And admission to hospitals for non-urgent medical care always requires a referral based on doctor examination. Treatment must be arranged and start taking into account the urgency of the treatment within 6 months of recognition of the need for treatment. The waiting list have increased from around 30,000 in August 2018 to the July 2022. The statistics show that the number of people waiting between 1 and 19 days has remained stable since 2018. A steady increase can be observed among those waiting between 91 and 180 days. The highest increase has been recorded in the proportion of people waiting for more than 180 days. This is also marked by a higher increase in 2020, which is likely to be related to the prevalence of COVID-19. In 2018, around 3,300 waiting for more than 180 days. And this year, there were around 18,900 waiting for more than 180 days. The proportion of waiting list for more than 180 days has increased by 9.3% during the COVID-19 period. COVID-19 has affected the number of consignments. In August 2018, some 150,000 more referrals were received for specialized care compared to July in this year. And these referrals numbers are cumulative from the beginning of the current year. And the next one slide. Yes, that is the referrals. This is the situation of waiting list in Finland in brief. This situation is currently aggravated in Finland by the availability of staff, where the dismantling of waiting list poses additional challenges. Thank you for all.
Thank you very much, Pia. So you can see that there is quite an impact then also on people waiting long times in the Finnish system. Now I'm very curious to hear about France, a country that I know doesn't systematically track waiting times, but there are other ways, and I think Aidan is going to show us how.
Yes, thank you very much for the invitation. I hope you can see my slides, although I'm going to be, of course, a very quick perspective and have more works on that, but I'm going to give you a quick perspective from a French payer. So we are insuring 95% of the French population, and most of the data we can rely on is claims data. So these are reimbursement data, and so we measure, we can try to at least assess the backlogs through the volume of care provided and reimbursed. It is important to say that we have only recently started working on waiting times, and the first survey, the first national survey, was published, but for the consultations for a GP. So these are not things we are used to use as policy tools, but it's going to develop. So what I can say about the backlogs, the first thing I'm going to focus on is the global surgery. So what you can see on the left-hand side of the slide is the difference year by year since 2013 to 2021 in the volumes of surgery. In green, this is day surgery, and in red, this is we call conventional surgery. So this is the non-day surgery. What you can see is that we have an important dip between 2019 and 2020, which we estimated was around 1 million procedures. It's about 18% of the overall activity that we would have expected if in 2020 we had the same activity according to the trends of the previous years. So this is a very important gap. And as you can see, the next year, 2020, 2021, we have a great increase in the activity, mostly through day surgery. And the net effect of the 2020 and 21 years is about, still we have a backlog, we estimate around 350,000 procedures overall, which is about 5.5% of the activity, which is still quite a lot, but it's been reduced. On the left-hand side, of the slide, what you can see is that, of course, this is very different. As you can also, we have seen this in Spain, according to the surgical specialty. So you have here the net effect for all surgical specialties, and the limitations of working in volume. And I think it's important to say it's been a little, this matter has been talked about by Luigi, but it's very important. We don't know whether the care is appropriate or not. This is a very important matter, because for some specialty, we know that there is some inappropriate surgery, inappropriate procedures that happen. So when you focus on volume, you don't know whether the care was appropriate or not. So that's the first limitation of that sort of measures. The second is that, of course, we do not see unmet needs, because what we see is the procedures that were performed and reimbursed. And of course, there is another very important issue, and we're going to focus on it about cancer care, is that maybe the need is no longer in place because the patient has received an alternative treatment. And this is something we see. If you look here at colorectal cancer, we have a run chart of screening. So the red line is the fecal occult blood tests. And you can see it's by month between the January 29 and November at the end of 21. The red line is the colonoscopy, and the blue line is the cancer surgery for bowel cancer or colorectal cancer. So you see there is a huge dip in March and April 2020. This is the first lockdown, but what you can see is that while the fecal occult blood test went up, the other one were slightly a little bit up to the previous level. So if you take a cumulative vision of all that, on the left-hand side, this is the tests, fecal occult blood tests. You can see that if you compare 2021 with 18-19, 17-18, and 16-17, we have caught up with the backlog, you see, at the end of 21. But if you look at procedures-oriented things, such as colorectal surgery or colonoscopy, we still have waiting, but we still have, a backlog that probably amounts to about 3 months worth of activity. So that's a question whether the people who have a positive test here could access to this, and we cannot see it through volume. And if you look another cancer, and I shall finish on that note, this is breast cancer, and you have mammography, it's the blue line, and breast cancer surgery, this is the green line. What you see is we have caught up with the backlog for breast cancer surgery, mostly, and this is feedback from the frontline teams, mostly through the use of day surgery, which goes back to the first slide I showed you. So you see, it's very interesting to have this volume follow-up, but it probably is not enough to have a vision of exactly what happens to patients, what are the results on the outcomes for patients. And so we have a number of surveys now still ongoing, notably to track the whole pathways of patients between screening for fecal occult blood tests, whether they have colonoscopy, whether they have it timely or not, and then surgery to complete these visions, which have the really great advantage that we can, its claims data are easily available, easily analyzable, so we can provide the run charts very easily. So many other things I could have said, but I think my time is up. So thank you very much for your attention.
Thank you very much, Aidan, for this very interesting information, detailed information, how it is affecting the French system. I would now like to go to Erica to see what has been happening in our chat. Erica.
Hello, everyone. Quite a lot of activity in the chat box, which is always exciting to see. Quite a lot of questions have been around policies to address the backlog and what has worked, what hasn't worked. So if we want to look at that, we can, but also more specific to measuring backlogs. Some quite technical questions about using operational research, queuing theory and things like this, but also what has been the limiting resource, the operational constraint when dealing with backlogs. And how can we ensure data reliability, data quality for when we're actually measuring backlogs, and what resources are we going to need to actually meet the backlogs? So those are the sorts of questions that are coming up so far. Maybe we'll get in a second round. Thank you.
Thank you. So I would like to ask all the speakers to switch on their cameras. And I think I would like to start with you, Luigi. Would you like to take that first question about the use of operational research and perhaps also a little bit about what are the main constraints?
Thanks for that question. I mean, there is a long tradition of using queuing theory to understand the waiting list problem. So this has been going on for a lot of time, and I'm happy to pass some references on that. I mean, in the end, what I was showing in those graphs can be seen like as a simplified queuing theory model, where what you're modeling is like the waiting list as a difference equation that evolves over time as a function of the additions to the list and the supply. And what operational research can and queuing theory can allow you to do is to analyze some feedback effects. So if you can think maybe the additions on the waiting list depends on how long the waiting list is, where in theory actually should be the waiting time. So there are like some methodological issues, and probably the ideal method would be like where queuing theory meets some economic theory as well. But this has been done in the literature, so you can use. But what I would say is that there is like a spectrum of methods, and you can be incredibly sophisticated, but you can also keep it quite simple. And maybe the additional layer of sophistications maybe that we wouldn't change the results so much from a relatively simple model. In relation to the constraints, I think maybe what this question is about if you're thinking about boosting supply, which is what many policymakers are trying to do, which one is the binding constraint? And I think this depends on the country. So in some countries, we can see that is the health workforce. I mean, that's what everyone is talking about. But in other countries, it could be the capacity. In England, we have also bed occupancy rate, which is very high, above 85%. So I think to boost the supply, you really have to think about the capacity constraints, and is it labor or capital or the capacity. So I think I'll draw there, and I have some thoughts on the Spanish and Finnish and the French presentations. So I hope that I can come back to that point later on.
Okay, I'll reserve a spot for you for that then. I thought the other question was also a very interesting one, and perhaps a good question for our national spotlight speakers. About the data quality. How do you ensure data quality? Is there a mechanism? Is there a process? If you collect it from the providers, is there maybe an incentive for them, not to give the full picture? So maybe Anna, maybe you can give your how do you do this in Spain?
Well, as I was mentioning in my presentation, one of the main problems with the Spanish data is that it's not constant over time. It's not homogeneous over time. So I don't know, because I'm not sure. I don't know if we assess this data quality.
Okay, so
yeah. And this has been a problem over time. I mean, as I was showing, Madrid took many years to send the data to the ministry, Catalonia even more years. That's because it's on the news, when the official statistics appears, it's on the newspaper.
Okay, so you could assume that it is an issue, and you also think it is also responsible partly for the huge variation.
Yes.
Is it similar in Finland, Pia? Maybe you want to come in here? Or do you have a system and audits and?
We have a big challenge with today. It's a highlight is the shortage of staff. It's big challenge, and even we have next year we have big change, and our hospital districts stop, and hyvinvointialue, it's a health and wellness area, is beginning, and we have 20 wellness and health area, and the system is just different like this day, and it's big changes. That's databases also, and I think yes, it's many problems and challenges to sort it in in this autumn and next year.
Okay, so I think that if this is indicative for other countries as well, there may be a problem. So Luigi, maybe this is a paper for the future to work also in this area. Luigi, you said you had a question for the country speakers. Maybe we can go to that before, and then I'll go through the other questions and see what came up.
I found those data really interesting for Spain and Finland. So the comment I want to make is that the waiting list, the wait seems to have grown in those two countries. It doesn't seem so dramatic, which seems to be like, you could interpret that as good news. But then I was a bit worried by a couple of other comments or graphs that showed the referrals really seem to be a bit low in Finland. So, and then Anna also said, yeah, well, actually you cannot really see a specialist. People couldn't really see a specialist for a long time. So if the reason why the waiting list has not gone up by much is because you just couldn't see a specialist who could put you on the waiting list, well, that's really reflects a bit the concern about unmet need that we were discussing before. So in that sense, that matches nicely with the analysis I was trying to make, that if you're a bit stuck in two scenarios, both of which are not great. Maybe the waiting list doesn't grow so much, but then if this is because people are not being put on the waiting list, that's not so good. If they are put on the waiting list, then the waiting list grows quite a bit. And then, well, I wanted to thank Aidan for bringing up the whole issues about inappropriate treatment, because that's quite important. But that's also, I think, it's a quite tricky issue because potentially you could see this as an opportunity to maybe make health systems more efficient by eliminating all these inappropriate systems. But are we sure about that? Or could actually this increase inequalities quite dramatically, because who is getting the treatment and who is not getting them? If it is actually the poor people and the one with worse health who are not getting it, then actually we're not doing a very good job. Okay, so those were my reflections. Thanks.
Yeah, maybe Aidan, you can reflect on that, because that was also the question I had for you. You flagged it up. Maybe there's inappropriate care and waste. What are your thoughts, and what can be done about it in a way that it's not harming or furthering, widening inequalities?
It's a very, very good question, as you say, and very tricky, because obviously nobody is billing a hospital stay saying that it is inappropriate. So we have to, usually we rely on a geographic variation of the referral or the use of surgery to try to assess whether it's appropriate or not. But it's very difficult when you are faced with one specific surgery to say that it actually was inappropriate. So what is certain is that we completely almost stopped every surgery for 2 months. So basically, I think that every inappropriate intervention was stopped. The question is, how do you ensure that while catching up, you try to give incentives so that appropriate care is the one that goes up and inappropriate care is the one that does not go up. And so I think that it has also something to see with the fact that healthcare professionals have stopped working for 2 months and they have to get their money back. So when they go back to work, probably there's a huge incentive for some of them to perform care, whether it is appropriate or not. So I think it's a mixture of tools on the front line, how to triage patients. I've not talked about that, but there are tools that have been developed on the front line in the regions to help professionals do that. And probably also reflection on how payment mechanisms can be adapted so that we incentivize more catching up of appropriate backlogs and try not to give incentive. But it's an ongoing work. Now we're trying to, it's a survey we're now trying to do is to look whether in the regions of the departments where we had the higher levels of surgery and we thought there was inappropriate care, if they caught up more rapidly than others, and try to see if we can see some trends so that we can build policies and actions around that. But it's so far it's been proved very tricky. So it's mostly a rhetorical question, unfortunately, although I think it's a real point.
It's also really an area of work I think that we are interested in and also pursuing perhaps in the near future to understand this better. Eric, I'm just coming back to you real quickly for maybe 1 or 2 final questions, because time is running out, obviously. It's been very active in the chat box, so
very active. Yeah,
follow.
I'm still reading.
Yeah,
okay. So short technical question. So how can we separate natural growth in waiting times, waiting lists, from the backlogs and actual COVID-19 effect? Is there a way of separating the two things out? And what's the international experience of separating planned and unplanned work between sites? to prevent the sort of emergency care just swamping all the planned work. So that's a question from our colleagues in the Nuffield Trust. So thank you very much.
So maybe to start with the letter, I don't know, Florian, it does it speak a little bit to you know, the wider focus of our policy brief. Maybe you want to share some thoughts on that issue.
Sure, Ewald. I mean, we've worked with the Nuffield colleagues quite a bit on this, so they're of course experts in the fields just as much as we are, WHO. With what I can say that when it comes to the monitoring really and on measuring the effects and the size of the disruptions and the backlogs, we have seen that at least getting some data in as sometimes patchy as it might be, right? And as I mentioned earlier, as heterogeneous as it might be, and really not easily comparable between countries and among time trends, and it's better than getting non-data in at all. So with the pulse survey, even though we have had different countries responding at different times onto different questions, also there was the self-selection bias. Whatever we had got in has been proven hugely valuable, both within WHO as working on our normative guidance and then working with this data, but also for the countries themselves who had then been able to use it within their own planning processes. Planning for procedures that were short-term, planning everything COVID related, and also long-term seeing, well, how they might be able to then tackle those backlogs and what policies they might implement in order to clear the backlogs and build back better to the extent possible. So I think it has a good value and it can always be improved without a doubt. But most importantly, of course, it was for the countries themselves and not an exercise that had an inherent value for WHO only, to really understand their size of the problem and take it from there in order to find solutions. Okay.
Luigi, perhaps you want to take the other question about separating natural growth from you know, the COVID pandemic. And I'm actually wondering, does it matter? Don't we just need to tackle both?
Yeah, no, I'm very happy to take that question. So I think that in some way that growth in waiting list can be a little bit misleading, because you know, the waiting list tends naturally to grow just because more patients are in the system and are treated. So you could try to standardize that by dividing by the volume, but I think a better way is actually to look at the waiting time. Because if you plot together the waiting list, the waiting time, you will see in some countries that the waiting time can be quite stable, even though the waiting list keeps increasing. So you really should monitor closely the waiting time rather than the waiting list. Yeah, so I think that's my answer. And I think Nigel asked good questions about the planned versus unplanned, which I'm not aware of many countries that have tried to do that, to ring. I mean, I think the main problem in England to try to ring fence the planned care is that who's going to do the emergency care. So you know, so that seems to me the tricky. The last point I want to make about France is that I think it is really nice that France was able to catch up. I think this is like one of the first data that I see that you know, it is possible to catch up. I haven't seen that for many other countries, so that seems like a very positive development. Maybe that's something that other countries can learn from the French case studies. Though we know that the institutional setting is quite different, and the financial incentive, you know, maybe a bit more towards fee-for-service, you know, could explain that how that recovery could be facilitated. Thank you.
Well, we will just keep inviting Aidan to talk about the French experience. We book him for the rest of the year. I already told him this before we had this meeting, you know, so that we will be informed and on top of things in France. I would like to close the meeting now, and what we always do, Luigi, is to give you the final takeaway. What is, you know, your final thoughts before I close?
Yeah, I have like two final thoughts. Well, one is actually in relation to one of the questions that were put in the chat that I think made a very good point that maybe we have missed in the discussion, that you know, for some patients, the very long delay could cause all sorts of problems in terms of worse health outcomes, especially if you think about cancer care or even cardiovascular disease. So I just wanted to acknowledge that point, that you know, that's in the discussion about efficiency. Is quite important that that comes out, because there are inefficiencies that arise from the very long waiting time. The very final point that I want to make that relates to measures is that for countries that are not the usual suspects that want to develop indicators on waiting times and waiting lists, you know, there are options. So I hope that I try to convey like which one are the main options and what you can do depending on the constraints you have. But even if you have limited resources and limited time that you can invest in this, I think we have good options to try to monitor the backlog so that maybe that can help policymakers to inform the recovery. Thank you.
Well, thank you very much, Luigi, and also a big thank you to the other speakers today for their contributions. I would also like to thank the audience for joining us today and joining us also in our future webinars. Would you like just to point out that we have a YouTube channel where you can watch back all these webinars. I think there are more than 40 or 50 now, by since 2 years. So it's really a good source. Also sign up for our newsletter and also stay so that you stay on top of these, and keep your eyes peeled for new webinars that will be posted soon. So that's it, and hope to see you soon. Bye-bye.